In this video, I will explain you what our alignment philosophy is in total knee arthroplasty, and more precisely, how we restore the natural or constitutional alignment of the patient using the CPAK classification. When considering alignment in knee replacement, it is important to realize what the natural alignment is in your patient. And contrary to what we all have learned in the past, this is not always 0-degree mechanical. What the normal alignment is in humans has been very thoroughly studied by us, and we have published our findings in 2012 in this landmark publication in Core. And indeed, contrary to what was thought before, the natural alignment of the knee is not systematically 0 for everybody. It is, on the contrary, highly individual with a bell curve or Gaussian distribution around an average of 1.3 degrees of varus with a standard deviation of 2.3 degrees. Meaning that 95% of knees are situated between 6 degrees of varus and 3 degrees of valgus. And also meaning that an important fraction of the population, approximately 1/3, has a natural alignment in varus, and we have called that constitutional varus, from the Latin word constituere, which means building. So how you were built or constructed after skeletal maturity and before any degeneration and axis deviation has taken place, that is your constitutional or natural alignment. And in 1/3 of the population, that is in more or less significant varus. Now, these patients with constitutional varus, they pose a problem with standard mechanical alignment restoration to 0. Because when you do so, you see that you run into a conflict with the soft tissues on the medial side. Cutting perpendicular to the mechanical axis to the femur and the tibia then indeed leads to an asymmetric extension space, where you can never get the rectangular prosthesis in between, unless you release or stretch or partially disrupt the medial collateral ligaments and the medial soft tissue sleeve, which of course is a strange thing to do, because it would mean that you correct a mistake by making another mistake, that is, damaging the medial soft tissues in order to obtain a rectangular extension space. Now, while we looked at the normal alignment distribution in healthy population, we noted that amongst the individuals with constitutional varus, there was another factor of variability within this group itself, and that is the joint line orientation. And that same variability we also noted in the neutral knees, as well as in the group with constitutional valgus. That same variability in joint line orientation was present. And this observation led to the second landmark publication that was published by Dr. Sam McDessie and Dr. Darren Shan from Sydney, Australia, Dr. Bill Griffith-Jones from the UK, Dr. Harris from Australia, and myself from Belgium. In this publication, we present the CPAK classification, which is based on these two observations. That is, the variability in knee alignment, as well as joint line orientation that is present in healthy or normal individuals. So this is the CPAK classification. It subdivides and classifies the different knee phenotypes into a matrix of 9 different types, depending on overall alignment and joint line orientation, which are, as I explained, the 2 factors of importance. So the matrix has 3 columns and 3 rows. In the columns, we see the overall alignment. In the rows, the joint line orientation. So in the first column, we have the knees that are in varus alignment. The second column, the neutrally aligned knees, and in the third column, the knees that are in valgus alignment. In the rows, we have the joint line orientation. In the first row, we see the knees with apex distal joint line orientation. The second row, the knees with a neutral joint line orientation. In the third row, the knees with apex proximal joint line orientation. So any knee can be classified or positioned in one of these 9 boxes. And this can be by just visual assessment of the full leg radiograph, or more precisely by using 2 simple mathematical formulations. The first formulation is MPTA minus LDFA, which defines the alignment. And we call this the arithmetic hip-knee angle. So MPTA, the medial proximal tibial angle, minus LDFA, the lateral distal femoral angle. When MPTA minus LDFA is negative, in other words, MPTA is smaller than LDFA, then the knee is in varus alignment. If MPTA minus LDFA is 0, the leg is in neutral alignment. If MPTA minus LDFA is positive, the knee is in valgus alignment. The second formulation is MPTA plus LDFA, so the summation of both. This defines the joint line orientation. When the summation is less than 180, the apex of the joint line orientation is distal. If the summation equals 180, the joint line orientation is neutral. If the summation exceeds 180, the joint line orientation is apex proximal. So with these two formulations, you can easily assess what type of knee you are confronted with, where it sits in the matrix, and what its natural alignment and joint line orientation is. In other words, which CPAK type it is. Here you see some practical examples. Now it is interesting to note that in the normal Western European population where I live, our data show that most knees are located in CPAK 1, 2, 3, 4 and 5 categories. In other words, apex distal with overall varus or neutral alignment. And by the way, this work in the meantime has also been done in Japanese and other Asian populations, which in general show almost exactly the same distribution as in our data. Now, here you see a very interesting slide of arthritic patients, so patients with knee OA. And what you note is that the distribution of the clouds or dots or patients is not so much different. It is a bit more spread because of the OA and also what more to the left because of the increasing varus during OA. But overall, it is pretty much the same. Most are CPAK 1, 2, 3, 4 and 5. So apex distal and overall varus or neutral alignment. So pretty much identical to the previous slide, the healthy patients. And that is very logical because during the progression of OA, MPTA and LDFA only change in the very late stage of the process when bone erosion has occurred. And until then, what mainly progresses is GLCA, the joint line conversion angle, which is caused by progressing cartilage wear and progressing ligament laxity on the convex side. So that means that MPTA and LDFA are very reliable parameters to judge what the original constitutional alignment and joint line orientation of the knee were, and therefore this makes the CPAK classification a very reliable tool to determine so, and to restore both constitutional alignment and joint line orientation in the most optimal way during surgery. Now let's go back to the surgery. As I have explained earlier, if you restore mechanical alignment systematically in all of your patients to 0 degrees, you regularly run into this conflict with the soft tissues because of an asymmetric or trapezoidal extension space. For this reason, some surgeons have suggested to cut parallel to the articular surfaces instead of perpendicular to the mechanical axis, and they have called this kinematic alignment. And as a matter of fact, this is a good idea, I believe, because it restores indeed the constitutional alignment and the CPAK type, at least in the little deformed knee, when there is not too much bone erosion. When there is, however, severe axis deviation or bone erosion, kinematic alignment becomes less reliable and even dangerous, I believe. The reason you can see here. This is a moderate to severe varus knee. If you perform kinematic alignment in this knee and you cut parallel to the joint line, you see that on the tibial side, this would mean a resection in severe varus, somewhere around 8 degrees or even more so in this case. And if there is one thing that we have learned from the past, that is that cutting the tibia in severe varus is a dangerous thing to do. For two reasons. One, if you cut the tibia in varus, this means that inevitably you will need to cut and position the femoral component in relative internal rotation. Otherwise, you will never obtain a rectangular flexion space. Now, if you position the femoral component in internal rotation, this will of course negatively affect overall rotation of the leg in extension. And you will medialize the troglia, which provokes lateralized patellar cracking and the risk for lateral patellar dislocation. Secondly, we have also learned from the past that a severe cut on the tibia, especially when combined to overall varus of the leg, increases the stress on the medial side of the knee, both on the prosthesis and the underlying bone, which may lead to accelerated implant wear or to migration or subsidence of the prosthesis, or to persistent pain on the medial side of the knee and the tibia because of the increased bone stress. So instead of cutting the tibia here in severe varus, it is, in my opinion, better to restore this knee to its constitutional status, in other words, to its original CPAK type, which in this example, if you do the calculations, is a CPAK type 4, meaning that the MPTA should ideally be restored to about 87 degrees. I will come back to this in a few minutes when we discuss specifically what our strategy is for CPAK type 4 knees. And this brings us indeed to the essence or the core of our philosophy, that is to restore the knee to its constitutional or natural alignment with help of the CPAK classification. So the first thing we do when we perform knee arthroplasty is to evaluate thoroughly the preoperative full leg radiographs and determine which CPAK type the knee is that we are going to operate. And we use the two equations to do so. MPTA minus LDFA to determine on alignment. MPTA plus LDFA for joint line orientation. And based upon this, we bring back the knee to its pre-diseased or constitutional configuration. So let's explain in detail how this works for each of the 9 CPAK types. So we start with CPAK type 1, which is a varus knee with apex distal joint line orientation. And this represents 26% of all knee types. So 1 in 4 knees are like this, CPAK type 1. To be this type, MPTA minus LDFA is below -2, and MPTA plus LDFA is under 177. So it is like this, varus, apex distal. Here you see an example, varus, apex distal. And this is typically how the knee looks like. So 26% of all knees are like this. But amongst the varus knees, its proportion is 83%. So most varus knees, 83%, are CPAKs type 1. Typical example coming in for surgery with an MPTA of 83 degrees, LDFA of 91 degrees. So 83 minus 91 is -8, so 8 degrees varus. 83 plus 91 is 174, so apex distal. What is our strategy in this type of knee? Restore MPTA to 87 degrees, so correct the tibial varus to its constitutional state, 87 degrees, and bring LDFA to 89, so 1 degree valgus. So 87 minus 89 is 2 degrees varus, 87 plus 89 is 176, so apex distal. So the knee is restored to its constitutional CPAK type, varus, apex distal. In case there is remaining disbalance with the soft tissues, in this case residual tightness on the medial side, I will increase LDFA gradually to a maximum of 92 degrees. So increase the varus on the femur to a maximum of 2 degrees, which is my upper restricted boundary. Typically, this will be in a case with severe varus bowing of the femoral shaft and a varus hip configuration with a low neck shaft angle. On the tibial side, my restricted boundary for MPTA is 85, so never more than 5 degrees varus on the tibial side. In total, my overall restricted limit is 6 degrees varus overall. So in other words, MPTA 87 and LDFA 89 are my standard settings, with some margin to adjust intraoperatively towards the maximal restricted boundaries in case the soft tissues would dictate so. CPAK type 2, neutral alignment, apex distal joint line orientation. And this represents 39% of all knee types. So almost 40% of all knees are like this, CPAK type 2. MPTA minus LDFA is 0 plus or minus 2 degrees, and MPTA plus LDFA is under 177. So it is like this, neutral alignment and apex distal. An example. And this is typically how the knee looks like. So 39% of all knees are like this. And amongst all neutral knees, its proportion is 72%. So most neutral knees have an apex distal joint line orientation, 72%. Typical example coming in for surgery with an MPTA of 87 degrees, LDFA of 87 degrees, so 87 minus 87 is 0, so neutral. 87 plus 87 is 174, so apex distal. What is our strategy here? Easy. Restore to MPTA 87 and LDFA 87. Logical and straightforward. Keep the knee into its CPAK box of type 2, neutral and apex distal joint line orientation. CPAK type 3, valgus knee, apex distal joint line orientation. 10% of all knees are like this, CPAK type 3. MPTA minus LDFA is greater than +2, so MPTA greater than LDFA. And MPTA plus LDFA is below 177, valgus alignment, apex distal. An example. And this is typically how the knee looks like. So 10% of all knees are like this. But amongst the valgus knees, its proportion is 73%. So most valgus knees, 73%, are CPAK Type 3 with an apex distal joint line orientation. Typical example coming in for surgery with an MPTA of 89 degrees, so 1 degree varus, LDFA of 82 degrees, so important valgus on the femoral side. So 89 minus 82 is plus 7, so 7 degrees of valgus. 89 plus 82 is 171, so apex distal. What is our strategy in this type of knee? Our strategy is keep MPTA at 89 degrees, reduce the valgus on the femur from 82 to a more reasonable 87 degrees. So 89 minus 87 is 2 degrees valgus remaining. 89 plus 87 is 176, so apex distal joint line orientation. In other words, the knee is safely restored to its CPAK Type 3 constitution. CPAK Type 4, varus knee, neutral joint line orientation. 5% of all knees are like this, CPAK Type 4. MPTA minus LDFA is below minus 2, and MPTA plus LDFA is between 177 and 183. Varus alignment, joint line neutral. An example, and this is typically how the knee looks like. So 5% of all knees are like this, and amongst varus knees, 17% are like this. So only 1 out of 6 varus knees are CPAK Type 4, with an apex neutral joint line orientation. Most varus knees are indeed Type 1s, with apex distal joint line orientation. Typical example coming in for surgery, with an MPTA of 85 degrees, an LDFA of 94 degrees. So 85 minus 94 is minus 9, so 9 degrees of varus. 85 plus 94 is 179, so apex neutral. What is our strategy in this type of knee? Restore MPTA to 87 degrees, so correct the tibial varus to 87 degrees, and bring LDFA to 90, which is neutral. So 87 minus 90 is 3 degrees of residual varus. 87 plus 90 is 177, so apex neutral. So the knee is restored to its constitutional CPAK type, varus, and apex neutral. Also here, similar to CPAK types 1, in case there is remaining disbalance with the soft tissues, usually residual tightness on the medial side, I will increase LDFA gradually to a maximum of 92 degrees, which is my upper restricted boundary. Typically, this will be in cases with severe varus bowing of the femoral shaft and a varus hip configuration with a low neck shaft angle. On the tibial side, my restricted boundary for MPTA is 85 degrees, so I never give more than 5 degrees of varus on the tibial side. In total, my overall restricted limit is 6 degrees varus overall. So in other words, MPTA 87 and LDFA 90 are my standard settings for CPAK Type 4, with some margin to adjust intraoperatively towards the maximal restricted boundaries in case the soft tissues would dictate so. CPAK Type 5. Neutral alignment overall, neutral joint line orientation. 15% of all knees are like this, CPAK Type 5. MPTA minus LDFA is 0 plus or minus 2 degrees, and MPTA plus LDFA is between 177 and 183. So, neutral overall alignment and neutral joint line orientation. An example, so 15% of all knees are like this, and amongst neutrally aligned knees, 28% are like this. So this type 5 is much less frequent than the CPAK type 2 neutral knees, which are apex distal and represent 72% of neutrally aligned knees. Typical example of a CPAK type 5 coming in for surgery, MPTA of 90 degrees, LDFA of 90 degrees. So 90 minus 90 is 0, so neutral. 90 plus 90 is 180, so apex neutral. What is our strategy here? Restore MPTA to 90 and LDFA to 90 degrees. Logical and straightforward. But one caveat, I don't want any overcorrection towards valgus. Not a single degree. Neither on the femur, neither on the tibia. I indeed never want postoperative valgus alignment unless the knee was in preoperative valgus. I'm very strict on this, so I would rather err towards slight varus if I'm not sure about my resection accuracy. CPAK type 6, valgus knee, neutral joint line orientation. Only 3% of all knees are like this, CPAK type 6. MPTA minus LDFA is greater than plus 2, so MPTA is greater than LDFA, and MPTA plus LDFA is between 177 and 183. valgus alignment, joint line neutral. An example. So, only 3% of all knees are like this. And amongst the valgus knees, 25% are like this. So this type 6 is much less frequent than the CPAK type 3 valgus knees, which are apex distal and which are the majority, 72%, of all valgus knees. Typical example of a CPAK type 6 scheduled for surgery. MPTA of 92, LDFA of 86. So 92 minus 86 is 6 degrees of valgus, 92 plus 86 is 178, so joint line orientation neutral. What is our strategy here? Restore MPTA to 90 degrees, so decrease the valgus on the tibia to neutral, and reduce the valgus on the femur to an LDFA of 88 degrees. So 90 minus 88 is 2 degrees valgus remaining, 90 plus 88 is 178, so neutral joint line restoration. In other words, the knee is nicely restored to its CPAK type 6 configuration. CPAK type 7, varus knee, apex proximal joint line orientation, is extremely rare. Only 1 in 500 knees are like this. MPTA minus LDFA is below -2, and MPTA plus LDFA is greater than 183. Varus, apex proximal. An example. Extremely rare. Only 0.2% of all knees and only 0.6% of all varus knees are CPAK type 7. Typical example of a CPAK type 7 scheduled for surgery, MPTA of 90 degrees, LDFA of 97 degrees. So severe varus on the femur, neutral on the tibia. MPTA minus LDFA is 7 degree varus, MPTA plus LDFA is 187, so apex proximal joint line orientation. So what is our strategy in this type of knee? Keep MPTA at 90 degrees, restore LDFA to 93 degrees. So MPTA minus LDFA is -3, so 3 degree overall varus. MPTA plus LDFA is 183, so apex proximal. In other words, we reduce the varus on the femur to a more reasonable and safe degree, restoring the knee safely back to its constitutional CPAK type 7, varus, apex proximal. In cases of tissues require more varus intraoperatively, we do so on the tibia, up to an MPTA of 87 as a restricted boundary. CPAK type 8, neutral alignment overall, apex proximal joint line orientation. Extremely rare. This is the configuration. Neutral, apex proximal joint line orientation. And extremely rare. Actually, this is the only one that I've seen in recent years. And I don't recall having encountered a CPAK type 7 for knee arthroplasty. So if you encounter a case for surgery, please let me know, because that would really be very exceptional, like seeing a Tasmanian tiger. Your case would then probably look like this: MPTA of 92 degrees, LDFA of 92 degrees, so varus on the femur, valgus on the tibia. MPTA minus LDFA is 0, so neutral. MPTA plus LDFA is 184, so apex proximal joint line orientation. So what is our strategy in this type of knee? As I explained, we have not encountered in recent years a CPAK type 8 for surgery, but probably our strategy would be to go for keeping the MPTA and LDFA as they are, avoiding any error towards increasing valgus, both on the tibia as well as on the femur. Because, as I've explained before, we do not want positioning a knee into valgus unless it was clearly in valgus prior to the surgery. Finally, CPAK type 9, valgus knee, apex proximal joint line orientation, extremely rare, only 1 in 500 knees are like this. MPTA minus LDFA greater than +2, and MPTA plus LDFA greater than 183. Valgus, apex proximal. An example. So extremely rare, only 0.2% of all knees and only 1.5% of all valgus knees are CPAK type 9. Typical example of a CPAK type 9 scheduled for surgery, MPTA of 96 degrees, LDFA of 92 degrees, so severe valgus on the tibia, some varus on the femur. MPTA minus LDFA is +4 degrees, so overall 4 degrees valgus. MPTA plus LDFA is 188, so apex proximal joint line orientation. What is our strategy here for type 9? Restore MPTA to 92, LDFA to 90 degrees. So reduce the valgus on the tibia to a reasonable and safe 2 degrees and restore the femur to neutral. So, with this, we have covered all CPAK types. I hope that this explanation is of help to you in your further planning and execution of the surgery. Thank you for watching.